All right, welcome to week 3 of our childbirth course. This one, we have a lot of medical terms in it, and so we're going to do our best to make sure we explain as we go. This is one of our meatier weeks. It's a little bit longer, so make sure you're in a comfortable position, and let's begin. All right, so we're starting with fetal monitoring. An external fetal monitor is a routine assessment. It's obtained using 2 devices that are placed on your abdomen. You can kind of see what that looks like in the picture there. One device records information about the infant's heart rate, and the other device records information about the frequency and duration of your contractions. Some health conditions or medications used during labor will require continuous monitoring, and those include labor-induced or augmented with Pitocin, infant heart rate has changed, you or your baby have a health problem in there, or if there's an epidural in place. All right, so internal fetal monitor. The fetal scalp electrode records the fetal heart rate, and then the intrauterine pressure catheter, or IUPC, measures the strength of uterine contractions. So this is similar to the last device, except for this one is internal, and your membranes must be ruptured for them to use this. If additional information is needed about your infant's heart rate, an internal fetal monitor can be used. A small wire is attached to the baby's scalp, as you can see in the photo. Sometimes this can leave a small mark on your infant's scalp, kind of like a scab. An intrauterine pressure catheter, the IUPC that we explained, can be used to measure the strength of your contractions and is placed around the infant's head. So that's the long one you see that's going all the way to the arm, that purple line. This is the most accurate way of obtaining this information, but your membranes do have to be ruptured before it can be done, meaning your water must be broken. Fetal decelerations and cord compression. So there are times when the cord can be wrapped around the baby's neck, looped around the body, or caught between the baby's head and the mother's bony pelvis. So with a contraction, the cord might be pinched and a decreased oxygen supply is delivered to the baby, which can be seen on the fetal monitoring device. This compression can sometimes be relieved with a simple change of mom's position. Oxygen is usually given to the mother, like we see in the picture, as well as positioning her on her left side. If the distress persists and is not relieved, then your healthcare provider may consider an assisted birth, given the head is low enough in the pelvis. So this would obviously be, if you're at the very end of labor. An assisted birth, meaning forceps or vacuum delivery, which we will cover next. If it's not indicated or something that can be readily done, a cesarean is usually indicated if the baby is not doing well. Forceps are not routinely used for birth. It is a hinged metal instrument that actually slides around the baby's head inside the birth canal. You can see that in the picture on the right. And then vacuum-assisted birth. The vacuum extractor is an instrument that is sometimes used instead of the forceps. As with forceps, your healthcare provider will pull the baby down the birth canal as the uterus contracts, and it may be used in place of forceps in some situations where assistance is required to help the baby through the birth canal. Often a bruise is noticeable on the top of baby's head, and that bruise will fade over time. But as you can imagine, they'll have like a suction cup on their head, so that's what the bruise will look like. And forceps, same deal, they can also cause bruising or scrapes, just birth trauma. So common reasons for the use of forceps: maternal exhaustion, inability to push because of your epidural, persistent posterior position of the baby's head, and then, of course, fetal distress. We want to get that baby out if they're in distress. So that leads us to cesarean birth. In cesarean birth, babies are born through a surgical incision in the mother's abdominal wall. Cesarean births are performed only when a vaginal birth is not possible, or like I said, when there is a concern for the well-being of the mother or the baby. Here are some common reasons a cesarean birth would be indicated. So we've got failure to progress in labor, irregular fetal heart rate, positions of the baby, which we're going to go over next. Another indication for cesarean delivery would be a previous C-section. And then I'll also talk more about cephalopelvic disproportion and placenta and umbilical cord problems in the next few slides. Okay, so here we have positions of the infant, which would indicate a C-section delivery. The upper left photo is of an infant who is in the transverse lie position, meaning they are laying across rather than up and down. Almost all patients who present with a transverse lie must deliver by C-section because it is way too dangerous for the infant to labor in this position. The next photos are of just various presentations of the breech position. So when the presenting body part of the infant is not the head, but rather the bum or the feet like we see there, this is called a breech presentation. Most women who present with a breech presentation in labor or with ruptured membranes and a breech presentation will have a C-section because of the complications these positions could have on the baby. Again, this will depend on your healthcare provider and what they feel comfortable with. Some other reasons for a cesarean. The most common reason for a C-section is the presentation of the infant, like we just talked about. However, there are other complications that arise that would indicate a C-section. So I'm just going to list those here and let you consult your healthcare provider on your specific risks for these complications. Alright, so some maternal complications indicating a C-section. Any serious medical condition of the mother that complicates her health or the infants by laboring is considered maternal complications, which may indicate a C-section. So these include a very premature infant, maternal heart condition, poorly controlled diabetes, preeclampsia or toxemia, a previous section, that means a C-section, with a classical or vertical incision to the uterus, ineffective contractions and or progressive labor, high blood pressure, active case of genital herpes, multiple gestations, so twins, triplets, etc., and prolonged rupture of membranes. And these are all things that you may want to bring up with your healthcare provider and talk to them what they would do in these circumstances and if you're at risk. So, a VBAC, or vaginal birth after cesarean, it's also referred to as a TOLAC, or a trial of labor after cesarean. These are just medical terms that would be confusing if you didn't work in the hospital, so we're just kind of going over those acronyms. A VBAC might be an option for many women, but no labor and birth are risk-free. So talk to your healthcare provider about the risks and benefits of a possible VBAC in regards to your individual circumstance. If you are a candidate, be sure that your healthcare provider and you agree that it's a safe option. You definitely want to be on the same page with this. Okay, so on to medications during labor. We're going to talk about local, epidural, and spinal anesthesia. So regional anesthesia blocks pain in the specific area of the body by numbing the area. So for the main medications during labor, there are two large groups or types. They are systemic and regional, and we just went over what regional means. Systemic affects your whole body and your baby. They are typically given in early stages of labor, so the medication has time to wear off of baby before delivery, and they were talked about in week 2. Regional medications block pain in a specific area of the body by numbing the area and providing relief. Again, like we said, local, epidural, and spinal anesthetics are known as regional anesthesia. So here we have this awesome chart. Local anesthesia is effective for the repair of tears, lacerations, or episiotomies after birth. It's going to affect only the skin area that is infiltrated, and this anesthesia is often used after natural childbirth if stitches are needed. You probably wouldn't need it if you had an epidural. You should be numb. Epidural anesthesia is the most common type of regional anesthesia used during labor. The anesthetic is injected in the lower back and provides pain relief in the lower abdomen, legs, and birth canal. It's most often administered through a catheter, which allows continual administration of the anesthesia without multiple needle insertions. So we're going to talk about spinal in the next few slides, but you can go ahead and read that over at this time. And we'll go into further detail about spinal anesthesia. Conditions that may preclude the use of an epidural would be neurological disorders, some types of previous back surgery, blood pressure problems, infection near the site of puncture, bleeding or coagulation problems, And at the bottom there, you can read if you have or suspect you may have any of these conditions, definitely let your healthcare provider know. And you're going to want to prepare for a natural delivery. So I'm going to put a little plug in for our Mindful Childbirth course that talks about pain management in labor and all the natural ways to help get you through labor. It's a super great course, and I recommend it whether or not you're planning to have a natural delivery, just because in labor you never know what's going to happen. Every delivery is different, every pregnancy is different, your first labor could be totally different from your second. So I think we have some really great coping techniques and skills to help you get through labor unmedicated, or I guess just even until you can get that epidural if you're planning on it.